Hey, good evening. It looks like some people are still logging in, but thank you everyone who's joined thus far for joining. I'm Dr. Joceline Fuchs, and I'm one of the MidLantic urologists here. So thanks for joining in on our educational kind of seminar on focusing on men's sexual wellness this time around. We try to do these series every once in a while. This time we're doing a little bit of everyone's favorite. So men's sexual wellness with a real focus on erectile dysfunction. We'll also touch on a couple other things as well, which I think are really popular, widespread issues that men deal with. They're all really important. And honestly, I think we don't really talk about them enough. There's something that I'm really passionate about. There's something that I really focus on for my patients. So hopefully everyone kind of takes something away. One of the things, just to have everyone be aware from the get-go, this will be a pre-recorded session. So there's always ways to revisit this. After the fact, you'll receive an email with a link, so you're able to kind of go back through things. We'll go through things relatively quickly. Second, very important part is that this is a completely private kind of closed loop circle here. So anyone who's on here is in kind of their private little bubble. No one can see that you're logged on. There's also an ability for you throughout the presentation to submit questions. And those are also private, and we'll go through those at the very end, kind of one by one. And it's a chance to kind of get curiosities answered from someone who's here open as a third party to give you an honest opinion. So there should be on the right side of your screen like a little thought bubble, and you can click on that. You can type in messages, and those will actually log in our question log book, and we'll go through those at the end. So without further ado, we'll get started. So first off, it's really important to really even understand what is the issue that we're talking about today. So we're talking about erectile dysfunction. We're talking about different treatment options. We'll also talk about low testosterone and Peyronie's disease as well. A little bit about myself before we get started. I am a urologist. I'm based primarily out of the Abington, Huntington Valley kind of Bucks County, Montgomery County area. I subspecialize in male reconstruction, sexual health, and prosthetics. I come from Texas, so I went to UT Austin for undergrad, did my training there as in medicine at Baylor, which is in Houston. Then I did my surgery and urology residency in Northwestern, which is in Chicago, and then did a reconstructive and prosthetics fellowship in men's sexual health at UT Southwestern, which is again in Dallas, before I ended up here. I'm one of many MidLantic urology physicians who are available to you. This is just a subspecialty focus for me. So the topics that we'll go through, once again, we'll start with the ED or erectile dysfunction. That's kind of the meat of the whole presentation. Then we'll touch on Peyronie's disease, which is curvature when you have an erection, and then low testosterone. So just to start, erectile dysfunction, what is it? Who has it? You know, the definition of erectile dysfunction is honestly quite broad. It is broadly stated the persistent inability to achieve or maintain an erection that is good enough to have sex. So there's a lot of different levels there that any man can be affected by. I mean, you could have trouble getting the erection. You could have difficulty getting an erection that's hard enough. You could have difficulty getting an erection that stays hard enough to actually have satisfactory sexual intercourse. So there's a lot of different levels there where there can be issues. They are all somewhat addressed in a very similar way. So we kind of group them all together. And it's honestly quite common. So men, even starting at a very young age, will have incidences of erectile dysfunction. So 1 in 5 American guys over 20 will have experienced ED at least one time in their lifetime. Once you get over the age of 40, it becomes even more common. We're talking about half of guys will have some sort of difficulty with erections or decline in erectile function, which is physiologically normal. And overall, if we actually just talk straight numbers, 39 million American men are affected by erectile dysfunction. And that's really only the men that are even coming forward. So you'd expect the actual incidence is probably much higher. How do erections even occur? Well, when it comes to erections, there are nerves that are involved. That's what kind of starts the whole domino effect. There are nerves that surround the penis. They also run very nearby the prostate. And when there's arousal, those nerves will start releasing neurotransmitters that change the blood flow to the penis. When it comes to erections and quality erections, it's all about blood flow, and we'll drive that point home today. But how things really start, arteries will relax. You'll see down here in this pictorial here, there's these two erectile bodies within the penis. The arteries relax, and then it allows just kind of this huge inflow of blood. When you get that inflow of blood, it causes that engorgement that you'll see. So you'll see expansion in length, in girth, and that's how you really get an erection. There's also that maintenance that's important too. So as those erectile bodies get really engorged with blood, they actually press on the veins that are on the outer borders of the penis. And that actually helps to trap the blood in place. So the expansion gives you that rigidity, but it also helps to further maintain the erection as well. The most common causes for erections to decline in quality are basically the stuff that happens as you get older too. So if you have any sort of vascular disease, so that's something like hypertension, coronary artery disease, anything that affects your peripheral blood flow, all of those things are also associated with erectile difficulties. If you have diabetes, and we'll delve into that, that's also a big cause for ED. A final one, and one that we as physicians and in the medical field kind of fail to recognize a lot of the time and really mention as a side effect, is a ton of very commonly used medications can also contribute to erectile dysfunction. So when you think about blood flow, anything that you are using to treat for hypertension has the potential for side effect of declining erectile function. Anything that treats anxiety, anything that treats depression, anything that treats nerve-related sensitivity and nerve pain, all of those can affect erectile dysfunction. It can also be a result of prostate cancer treatments. So that's what we see after you get a treatment for prostate cancer. While they're great at curing cancer, they also unfortunately have side effects like long-term erectile dysfunction. Diabetes can be a warning sign of diabetes. Erectile dysfunction in some ways is also thought to be the canary in the coal mine for early onset coronary artery disease as well. So we'll talk about that. But those are going to be the big three causes: vascular issues, diabetes, meds, and then to a lower level, it's going to be prostate cancer treatments, endocrine issues, nerve issues. What we do know is there's a lot of things that can cause ED, but ED, I think across the board, has a negative connotation for your quality of life. I think what is probably under talked about, it is a big problem for the guy who's suffering it, no doubt. But you're never an island. So sexual function and sexual satisfaction often includes a partner. So erectile dysfunction not only affects the guy who's having the issue, but also anyone that you're in a relationship to. So your partners too, or your potential partners. So now we'll kind of go into erectile dysfunction a little bit more about the nitty gritty. So we talk about the big three, and that's going to be diabetes, coronary artery disease, and then also prostate cancer treatments. So ED and diabetes are very closely connected. Diabetes is extremely common, especially in the Western hemisphere. So the United States is a big proponent of that. If you are diabetic, you are 3 times more likely to have or develop erectile dysfunction. It tends to occur at an earlier age. And the longer you had diabetes, the more likely you are to develop erectile dysfunction as well. In 12% of cases, if you kind of flip it around, in 12% of cases, erectile dysfunction and erectile issues can actually be one of the first presenting signs of diabetes. So before you start having a lot of urgency and frequency, before things, before you start having other side effects like eye issues or kidney issues with diabetes, erectile dysfunction can actually be one of the first things that shows up. When we talk about heart disease and how closely related that is to ED, it's all about blood flow. And that's what heart disease is about. That's what erectile dysfunction is about. ED can be an indicator of very silent or early stages of coronary artery disease. It can precede the kind of more clinical signs of ED about 2 to 3 years ahead of time. So it doesn't mean that everyone who has ED has an impending heart disease or heart attack pending in their future. But it does mean that if you have erectile dysfunction, you should probably be seeing your primary care doc for routine screening, as well as seeing the urologist to kind of get a hold on your sexual dysfunction as well. The physiology of why that happens, this is just a picture that shows you like comparison of sizes of blood vessels that you have. So the smallest on the left-hand side is going to be your penile artery. That's going to be the main blood flow to those erectile bodies that we looked at. Then you've got next some of the major blood vessels that supply your heart, some of the major blood vessels that supply your brain, and then also one of the largest blood vessels which supply your legs. And so you think about issues with blood flow, you're going to see it first in your smallest vessel. So that's going to be your penile arteries. That's why erectile dysfunction is often going to be that canary in the coal mine, the first sign that there's something wrong with blood flow, before you even see it with chest pain, before you see it with any strokes, and before you see it with claudication or pain in your legs when you're walking. You can reduce your risk of erectile dysfunction by overall, honestly, just following healthy lifestyle choices. So that's all going to be about diet, exercise, weight loss, reducing smoking, reducing stress, reducing alcohol intake. Everything that is probably good for your heart is also going to be good for the penis too. So these are things that inspire you to probably live a healthier lifestyle. If erections are what you need to drive you to kind of make the right choices, then so be it. But in general, the healthier lifestyle you live, the better chances you have of preserving your erectile function long-term. And then now we'll touch on prostate cancer. That's something that's very near and dear to a urologist's heart. We see it all the time. It is by far and away the most common malignancy that men develop after the age of 50. And so it's something that every man after the age of 50 should probably be getting screened for. 50, 55, sometimes even earlier if you have a family history. The reason why erections and prostate cancer really go hand in hand is the location of those nerves that really start that domino effect. Those nerves run right over where the prostate lies. So if you are to develop prostate cancer and you require treatment, which thank goodness is highly effective for prostate cancer, you are also likely to have collateral damage, and that's going to be on the nerves. Prostate cancer treatments, depending on what treatment you get, can really affect a man's ability to get an erection either on the immediate temporary basis after treatment or surgery, but there can also be long-term sequelae as well. So if we look at the actual rates of that, it's very broad reaching because every man goes into this with a very different baseline for their function. And then the different treatments that are available, whether it's surgery or radiation or hormones, all of those have the potential to have long-term effects on your sexual functioning. If you look at the actual like survey results, and take it for what you will, because this is very much patient-reported types of outcomes, it can range anywhere from 10 to probably 50% of men who are getting treated with either surgery or radiation. Now, let's talk about, okay, these are terrible things that happen. They happen to a ton of guys. What can we do about it? And I think we all want to turn what's pointing down to up. Things look a lot better when they're perky like that. There's a ton of different options out there. And we'll go through probably what I think is first line therapy, but then everything else that's out there when pills fail. One of the first things that I tell the men when I see them initially for erectile dysfunction is there is a way to get you there. Like where there is a will, there is a way. That way may not be how you may have traditionally thought about erections, but there is a way to get there. It's just whether or not there's a choice that works best for you, or if there's a choice that feels right to you, there's a way to get there. It may not be for everyone, but there's a way to get there. So we'll go through all these different options. I'll kind of focus on what I think works best for most men and how I think things really progress. So first line will always be pills. These are going to be your Viagras, your Cialis, your Levitra. They are widely available. And in the last 15 years or so, they've gone generic, which is great for guys. They used to cost an arm and a leg, and now they are incredibly cheap when you get them through a coupon system at like a Walmart, a Rite Aid, a Giant. You should be able to get 30 pills of any of these different varieties like Cialis or Viagra for about $20 or even less. How they work are really promoting blood flow to the penis. Again, it's always about blood flow. So how do we get it there? Pills are one way to get it there. They take about 30 to 60 minutes to take effect. The different formulas of medications will act on a different time scale. So there are some medications like Viagra that are better as an on-demand medication. Then there's Cialis, which is more of a long-acting medication. So you may have to take it more like an hour ahead of time, but it also stays in your system for a whole lot longer. There are different ways to get there. I think, pills are always going to be the thing that you start with. That can be initiated by either your primary care doctor or your general urologist. They are widely used. We're very comfortable with them. Primary care docs are also very comfortable with them, and they're very widely available now that they're generic too. They work for a lot of men, especially if you have mild to moderate erectile dysfunction, meaning you have trouble getting a really firm erection. You have trouble maintaining it, but you're still getting some filling there. You're still getting something on your own. Then pills are probably going to help boost that. There are some men who don't respond very well, and sometimes that's because the erections are truly more of a severe issue. Then pills can only take you so far. If you start out as a problem up here, then pills can't really bring you back to where you're going to be sexually functional and able to penetrate. There's going to be 30 to 35% of men who do not respond. People with diabetes and people who have undergone treatments for prostate cancer are probably less likely to respond as well. That doesn't mean that you shouldn't try them first. So there is no excuse to not try pills first. They're cheap, they're widely available. The side effects for them are generally very well tolerated. They have the potential side effect of things like a slight blue haze to the vision, maybe some nasal congestion, a little bit of headache. Some guys will get a little flushing in the cheeks, so you look kind of like you're blushing. Those are the most common side effects, but they're generally very well tolerated. When pills fail, which for 30 to 35% of men, they will, you move on to the next group of options. So the next one that I usually touch base with men on is something called a vacuum erection device, or VED for short. This is this external plastic apparatus. So you buy it through a medical device company. So you can even find them on Amazon these days. They're widely available. They're a one-time purchase, which is a perk. They probably cost somewhere between $200 and $400, depending on what type of model you get. There's either a manual pump or there's even a battery operated pump, but it works like a vacuum. So it draws all of the air out of the plastic tube, which is kind of fit over the penis. It draws blood into the penis. So it basically like sucks it in there. Once you get a good erection, then you take the tube off and you put a rubber ring at the base of the penis. And it just helps to kind of maintain. So it helps to keep the blood internal so that you have an erection that's good enough for penetration. Now, the vacuum erection device is also nice because it can be used as a non-surgical option. There's no needles, there's no cutting. It can be used in addition to other stuff as well. So if you take pills and you get some response, but it's not quite good enough, then sometimes vacuum erection devices can actually be that extra little boost to get you what you need to be able to have satisfactory sex. It can also be used in conjunction with things like penile injections that we'll talk about later. The downside of it is that, it's a little bulky. It's probably not the sexiest thing that you've ever seen. So you have to have a willing partner. You have to be wanting to have something like this. It's not for everyone, but for the guys who really like it, it is a very affordable, very easy and non-invasive method. There's urethral suppositories. We'll kind of gloss over this a little bit because I think this has fallen out of favor, especially in my practice. It's basically a rice-sized pellet that you insert into the urethra, which is the tube that you pee through. And there's like a medication there that kind of melts. You kind of rub it into the base of the penis, and it melts and absorbs into the tissues directly. The problem is that it is pretty costly. So the cost per use is unreasonably high, I think, for what you get. It can cause side effects with things like burning or like a little bit of like feeling like you need to pee, which is just an unpleasant thing to feel for some guys. And it doesn't work great on everyone. So I think it's something that you can try after pills have failed. But I honestly have very few men who actually choose to use this and stick with it. But it's out there. It's called Muse, or alprostadil is the generic name for it. The most common thing that I direct men to and have them take me up on after pills have failed is intracavernous injection therapy, or penile injections. It sounds really scary when you first hear about it, when you first have to think about it, because there is a needle involved in a sensitive spot. You can see in the picture there that you actually self-inject into the side of the penis. But my justification for it is this is an incredibly tiny and fine needle. It is the type of needle that diabetics use for insulin, which they use multiple times a day. It is very easy to learn how to use. And I think very rarely have I had men tell me, no, I can't do this because it hurts too much. It's not a pain thing. It's usually a mental hurdle. So if you can get over the idea of self-injecting, and if you're willing to try it, I actually have a lot of takers who really like using the penile injections. It is a direct injection of medication into the penile tissues themselves. So you're going to get a much more concentrated delivery of medication to the point where you need it. And because of that direct delivery system, it's way more potent, way more effective than pills will ever be. So if you don't respond to pills at all, you actually still have a very good chance that with penile injections, you'll get a good erection. If you respond to pills, but they're not good enough and they're not rigid enough, then injections absolutely will help, because you probably won't need very much to get you to where you need to be. The medication for penile injections does not tend to be covered by insurance. So that's one downside. It has to be refrigerated. So travel is not as easy. Like international or TSA-based travel is going to be a little bit more difficult because it has to be refrigerated and there are syringes involved. But you can make it work, especially if you're local or if you're driving somewhere. Cost-wise, I'd say most men, depending on what dose you end up needing, are going to have to pay probably somewhere between $8 and $15 per injection. And that all depends on what dose you end up needing. But I think that's a rough estimate of what it would cost you. So whereas with pills, you're talking maybe 50 cents a pill, with injections, it's definitely more expensive, but it does not tend to break the bank. We're not talking about hundreds of dollars each time. We're talking about like $10 each time. It works really well in a large proportion of men. So like up to 85% of men who try injections, who get to that point, will actually have a satisfactory response to where they're able to have sex. Now, injections don't work great for guys who want to be sexually active all the time. So let's consider that you're a younger guy who wants to have sex on a really regular basis, and you're injecting the penis 3 to 5 times a week or more, and you're doing that for 10 to 20 years of your life. That's a lot of needles. That's a lot of callousing that can happen. And so as a long-term frequent option, injections are not, while they may work in the short term, I don't think a lot of guys want to plan on doing penile injections for 20 years of their life. And so for guys who either injections don't work for, injections and needles are just too scary, or if it is, you're thinking long game, then something that I offer to men is going to be something like a penile implant. So this is how for every single man who has ED, you can get an erection, because there's a mechanical option. There's a surgical fix for this. The penile implant is not for everyone. It's not for the faint of heart, but for those who, I think, understand what it is and want something like this, I think it's a great option. The penile implant is a hydraulic system that's fully internalized. It's an inflatable penile prosthesis is kind of the medical term for it. And there are 3 pieces to that puzzle. There are cylinders that go and fit inside of the penis. There is a pump, which is actually inside of the scrotum itself. So you wouldn't be able to see it from the outside, like at the locker room, no one can see it, but by feel, you'll be able to feel something. And that's how you control this hydraulic system. And then there's a 3rd piece, which is like smaller than probably a silver dollar pancake. It's tucked into your lower belly. All of this is done through a small incision where the penis and the scrotum come together. But this implant goes in there and it gives the control back. So if injections don't work, or if injections are unreliable, or if you don't like needles, then penile implant is a very legitimate option. How it works is you push on this pump. So you basically inflate, you draw saline into the penis itself, and then it inflates the cylinders. So you go from like a flaccid look and feel to a rigid erection. The beauty of this is that it's mechanical, so it works the same every time. It goes up, stays that way, and then it stays that way for as long as you want it. You could have it up like that for 30 seconds. You could have it up like that for an hour or 2 if you so desired. There is no expiration date on how long the erection will last, because it's like turning on a light and turning it off. There's then a deflate button that is also there on top of that pump. You feel it, you press it, and it kind of puts things back down so that you don't have to walk around with an erection all the time. So it's there, available to you all the time. I think the perks of having something like a penile implant is when everything fails, this will always work. It gives you that predictable, very rigid erection that's very controllable by you. That includes not only when it goes up, but also how long it lasts. That doesn't get offered to you with any other approach. The downside of an implant is going to be that you have to go through surgery to get there. You can't reverse it. So after you have an implant, you can't take it out and say, oh no, actually I want to try injections now. There's no coming back from that. The surgery itself takes about an hour to an hour and a half under general anesthesia. So that is in an operating room in a hospital, but you get to go home the same day. You go home with a drain and a catheter and some dressing there. And then you see me back in the office. I take all of that out. You can't use the implant for about 6 weeks while you're recovering. With the implant, I would tell most guys, you're not going to like me so much for about a week or 2. So for a week or 2, you'll be pretty sore and you should plan to be a couch potato. And then beyond that, you'll start to kind of get back into your regular swing of things around weeks 3 through 6. At week 6, I teach you how to use it, meaning I teach you how to fully inflate and deflate. And then after that, everything is fair game. An implant like this lasts for about 8 to 10 years. So like a decently reliable car, but machines don't last forever. And so mechanical failure is something that does happen at about 8 to 10 years after an implant goes in. They can last for longer. I also conversely have men who wear through their implants sooner than 8 years, and I am more than happy to put in one sooner than that. But that's what you're looking at with an implant. I think implants are honestly very popular for men who have gone through prostate cancer treatments and men who have more severe and end-stage forms of diabetes and coronary artery disease. And that's because those guys are probably going to be the ones who have the worst erectile dysfunction. And so that's when something like a penile implant does come into play. But there's plenty of men who just get tired of using the injections and just move on to the implant just to kind of take the question out of the picture. We've talked about this a little bit. So in summary, I think we've kind of done a pretty good overview of erectile dysfunction. What does it mean? Who gets it? How common is it? What are the different treatments that we can address with it? And, you know, what can you really do to talk about it? So ED, in summary, it's extremely common. A lot of guys don't talk about it, but believe me, as a urologist who subspecializes in this, you are certainly not alone. You should not feel like you are isolated in this, because I see it all day long. and anyone who's not talking about it is just not verbalizing it. But over 50% of men who are over the age of 40 will have experienced some decline in their erectile function. It is natural. There's a lot of different treatment options out there. Some of that can even be started with your primary care doctor. So there is no reason to waste time and just sit around and suffer. There are things to try, and they're very affordable. Viagra, Cialis is all generic now, so it's a great option to start with. But if oral medications fail, which they do, then talk to a urologist. Talk to someone who's really interested in sexual function. There's me. There are other people who are local within MidLantic as well. I just have a certain personal passion about it, so it's something that I subspecialize in. But there are a lot of urologists out there who are able to offer these services to you. You can talk about things like vacuum erection devices. You can talk about intraurethral suppositories. You can talk about penile injections. You can talk about penile implant. If it comes down to things like reconstructive surgery and prosthetics, like a penile implant, I do tend to just recommend going to a urologist who really subspecializes in that. Not every urologist does a lot of them. There are some guys who do a lot more of them and more commonly. And when it comes to surgeries like these, you want to go to someone who's very comfortable with it. So just make sure that you research who you're going to see, and there will be a way to make appointments with different urologists within MidLantic. And so I think on our website, all of our different biographies are listed, but make sure that you're seeing someone who can kind of offer these different treatments to you, and ask about them if they're not being openly offered to you, because they're out there. So just to move on to some of the other kind of smaller topics that I want to touch base on, and I get questions about all the time, Peyronie's disease. So this is something that you may not recognize the name for, but you may have seen some commercials for it. If you've seen any of those commercials with the curved carrots floating around on a table and you don't quite know what they're talking about, it's actually different treatments for Peyronie's disease. So Peyronie's disease is a penile curvature that you see only with erections. When you're flaccid, you don't have any issues, but when you have an erection, sometimes you'll have a little curve to the penis. Now, a little natural curve with erections is actually normal, and that's physiologic. But sometimes if the curve is really severe, that's actually an indication of underlying plaque or scar tissue within the erectile bodies. And here you'll see this in the picture as a fibrous plaque. It causes curvature of the penis in any number of directions. It can be up, it can be down, it can be right, it can be left. I treat ones that are shaped like an S or a Z as well. So all different shapes and sizes can occur. It's estimated to happen in 4 to 10% of men, although the true incidence is truly unknown, because there's a lot of guys who have curves who never talk to someone about it. So we estimate it's probably more like 13 to 15%, but larger studies where people actually answer yes, the stated rates are about 4 to 10%. So penile curve with erections, that's really how you diagnose it. Some men will initially have some pain with erections. Sometimes you'll also see a little bit of loss of length and girth. That's something called an hourglass deformity. And so you just imagine that there's like a point where things almost look like you've got a belt on it. And that's a wasting deformity or an hourglass deformity. When that curve becomes greater than 30 degrees, so if you think back to your protractor days, 30 degrees is probably about here-ish, okay? So when you get to a curve at about that level, that's when most men will start having difficulty with penetrative intercourse. And so that's usually when they come out of the woodwork and start asking around about what options exist. A very common question I get is, why in the world did this happen to me? And about 10 to 15% of the time, we can actually trace it back to some sort of buckling event during an erection. So normally it's going to be sex, where there's some trauma. Sometimes you'll see some bruising afterward. You might have pain when you zigged when you should have zagged during penetration, if you get my sense. And it causes this immediate pain. Some guys will have lost their erection initially when this happens, others don't. And then over the course of 6 months to 2 years, you can almost see this really slow curve start to develop. And it can be a really gradual process. But that also means that 85 to 90% of the time, we never figure out where it came from. And we think that it could be because of some sort of unrecognized micro trauma. So some sort of trauma to the penile area that caused this scar to form. It also has an association with Dupuytren's contracture. So that's really trigger finger. So some people will have a trigger finger, and those guys are also more likely to develop things like Peyronie's disease. And that's thought to be related to, just more likely to form scar for some reason. So some people form scar in a very obvious way, others don't. Those who form really obvious scars are probably more likely to develop something like Peyronie's disease too. In the first 6 to 12 months when curves occur, there's unfortunately not a lot that you can do to change what's happening and what's going on. In general, what I recommend are regular erections. So the more you stretch out that area, the less likely it is to contract and really just cement down in a really smaller type of configuration. So regular erections. There are traction devices that are out there. So it's the same idea as almost a vacuum erection device where things stretch open and help to kind of stretch open that scar tissue. It's like rehab. Then I also will typically recommend things like some of those oral medications for erectile issues. And that's because it increases blood flow to the issue. It's all about stretching too. There aren't great studies, but a lot of people will talk about taking vitamins like CoQ10 or vitamin E or topical little creams. Those have never actually been shown to make a big difference. They probably won't hurt you, but they're probably not going to make a big difference either. When you get to the more stable phase of disease, so that's when things haven't changed and it's been 9 to 12 months out from when the curve started and it's no longer changing, the two different options that you have are going to be either penile injections, or called Xiaflex, or penile plication, which is a surgical intervention. Penile injections are a collagenase that try to eat away at that plaque, and those are given in the office over the course of about 4 to 6 months. 2 out of 3 men will see some improvement in the curve. There's going to be periods of time where you can't really have sexual intercourse after an injection, but it's a great office-based intervention to help improve curve. Penile plication is a surgical option. That's going to be an outpatient surgery where I actually mold the penis back to straight. So I make a small incision on the underside of the penis and then basically place stitches to kind of mold things back to the front. For me, it's almost like the plastic surgery that I do for penises in the operating room. It's like molding things like Michelangelo. I can usually with surgery get you back to about 10 degrees within full straight. And then the recovery time from that is about 4 to 5 weeks. And then finally, in men who have a significant curve and then also concurrently have a lot of issues with erections, then penile implants can be something that helps both of those, both corrects curves and then also treats the ED as well. Final, and this is, cannot be overstated how important it is. If it doesn't bother you and if it's a mild curve and it doesn't cause any problems with sex, you shouldn't do anything for it. Okay, so now moving on to low testosterone. I think this is a really popular topic as well. It's kind of come to the forefront, and I think that a lot of guys talk about it. They blog about it. There's a lot of YouTube channels about this type of thing, but there's a lot of misinformation out there as well. So low testosterone or hypogonadism, which is kind of the clinical syndrome that you can have, is when you have a low testosterone level, but you also have symptoms of low testosterone. So we'll go over what those symptoms might be, but it's prevalent in about 2 to 5.7% in men over the age of 40. The incidence of low testosterone increases with age. So naturally, the older you get, the worse things really work, both erections and testosterone production. So naturally, your testosterone goes down. That's why the older you get, the lower your testosterone becomes. There are other things that play into overall sexual health, including testosterone. Those will include obesity, diabetes, high cholesterol, high blood pressure. There's also some lifestyle choices that play into it as well. So smoking, regular marijuana use can also affect testosterone production. Heavy drinking and regular drinking can actually also play into it as well. Symptoms. So these might be symptoms that we associate with low testosterone. There are physical and then also mental and emotional ones. So it's a very broad concept that we think about when we think about low testosterone symptoms. You could have things like fatigue, decreased muscle mass, or difficulty attaining muscle mass with exercise. Conversely, there's an increase in body fat levels, hair loss. You can experience hot flashes and sweats as well. Depressed mood, decreased concentration, and low libido, erectile dysfunction. Those are all things on the mental emotional side that are also associated with low testosterone. The difficult thing is we have all these lab definitions of low testosterone. We have a very broad list of symptoms that you might have with low testosterone as well. The problem is, that a lot of those symptoms on the previous page, those are things that unfortunately people who are working, stressed, or have like just life stress or are getting older, those are extremely common symptoms for a number of reasons that you might experience. So it's hard to always hone in and say, and pin it on a low testosterone level. But if we are to find presence of one or multiple of those symptoms, and you get 2 separate early morning lab tests that show that you have a low testosterone level, then you are a reasonable candidate to consider testosterone supplementation to see if it improves those symptoms of physical or emotional low testosterone. Now, if we were to supplement testosterone and then we come back, see each other a couple months later, and you're seeing no change in your physical and emotional symptoms that started us down this road, then the reason all of this is going on is unrelated to testosterone. There's only one way to know, though, and that's really to try to boost up that testosterone and see if that improvement comes. I think, unfortunately, the way that testosterone is advertised and kind of thought about in a pop culture context is that it's a fountain of youth, and it is certainly not. There is no amount of testosterone that will make you back to what you were in your 30s. There is no amount of testosterone that will solve all of your anxiety and stress in life and fatigue from just having a busy lifestyle. There's no perfect fix for that. But testosterone supplementation can be one piece of that puzzle, one piece to kind of improve your starting point so that then you can also live a healthier lifestyle, have an overall improved quality of life. And that's how I really think about testosterone. I see it as one way to kind of improve your overall quality of life, but I never see it as a one-time and only fix for everything. There are a lot of different ways to get supplemented with testosterone, and there's good and bad for all of them. Some of it has to do with cost. Some of it has to do with method of giving it. There's oral meds, there's gels and topical solutions. There's nasal sprays for really quick acting. There's implantable pellets that are infrequently given. There are injections that you can give in the home or even in the office every several weeks. And then there's also oral medications that are more directly replaced. There's different pricing for all of these things too. And so a lot of this depends on how you want to get supplemented, but then also insurance coverage and what you're willing to kind of pay for convenience too. So that's something that a lot of urologists are able to manage, but not every urologist is likely to be able to manage your testosterone levels. I think those who subspecialize in men's sexual health and erectile dysfunction, infertility, they're usually the ones who are probably more apt to be able to help with low testosterone issues. So overall, I know that was kind of like all over the place, tried to hit the high points of what I think I see in practice all the time that a lot of men are interested in. And now I'll kind of start going down through questions that are private again, but I'll kind of read them out for the group and then we'll talk through stuff. There are a ton of different treatment options. Talk with your urologist. If there's anything that I can help with, I'm always happy to. MidLanticUrology.com is going to be the overall kind of practice website. So a really great resource to find a local urologist. The phone numbers for all of the different locations will be on there as well. Just as a summary, I think we've talked about all of that. My name is Dr. Joceline Fuchs. So in case anyone has to log off and you're looking for an appointment, you can always look me up on that website. Okay, so kind of to start from the top, I'll start from the first questions that trickled in and then kind of work our way down. Let's see. So the first question, there was someone who was asking about kind of over-the-counter or mail order type of supplements to help with erectile dysfunction. There are millions of these out there. If you've ever Googled them, you will immediately start getting targeted ads for these probably. In general, most of these are not going to be particularly helpful. They're never going to be as good as the prescription strength medications like Viagra, Cialis, injections, surgery. That doesn't mean that you can't try them. And it doesn't mean that there isn't some benefit, even if it's a placebo effect and like a psychological improvement. In my practice, anything that gets you to a point where you're more functional and happier with your sexual performance, I actually fully support. But I would usually steer people away from paying a lot of money for these supplements that are usually touted online as like miracle things that people will submit commentary on, like patient reviews, because I would just take it all with a grain of salt. Next question. Is there a time when Viagra doesn't work anymore? And the answer is yes. So a lot of men will have Viagra and it initially works, and then over time, things don't work as well. That tends to be just not you getting used to the medication, but that your underlying erectile function is just going downhill a little bit. And so the medication can kind of boost you from here to here. If you're starting at a lower point year over year, then you're going to have a harder time getting to where you need to be with the pills. And that's when people kind of move on to that second, third step, like injections, a vacuum erection device, or surgery. Is an hour before sex the right time to take Viagra? Yes. The best way to take Viagra specifically is about 30 to 60 minutes beforehand. It's best absorbed specifically on an empty stomach. And you still need sexual stimulation and be emotionally involved for it to work. If you take it 2 hours ahead of time, it's probably not going to hit you at the right time. The next question is, are blood thinners a cause of ED? So no, blood thinners specifically. So if you think about aspirin, Xarelto, warfarin, Eliquis, Brilinta, all of those don't really cause erectile dysfunction. Now, what can cause erectile dysfunction is the other condition that you're taking the blood thinner for. Most guys aren't taking blood thinner for no reasons. Most of the time you're taking a blood thinner because you have some sort of other condition like coronary artery disease, a prior stroke, high blood pressure, blood clots. Those are things that are all associated with poorer vascular function, and that is associated with erectile dysfunction. So blood thinners themselves are not a cause of erectile dysfunction, but if you're on medications to treat high blood pressure or high cholesterol or blood thinners, then you probably have other conditions that make you more likely to have erectile dysfunction. Next question is, please explain dry ejaculation. So dry ejaculation, a lot of guys link ejaculation to erectile function and orgasm, and actually they're completely separate entities. And that's important to understand. So erections are blood flow to get you the erection. So that is physiologic. That's what all of these different treatments will help you with. Pills, injections, VED, surgery for a penile implant, those all help you with an erection. Orgasm is more of a neurologic upper level type of climax that you can reach. So that is something that a urologist cannot help you with because that tends to be more mental and emotional. Conversely, ejaculation is just the physical process of having semen or prostatic secretions come out when you orgasm, but they can all happen separately. So you can have a good erection and never reach orgasm. You can have an erection and reach orgasm, but then have a dry ejaculation, but you still orgasm and you still have a good erection. You can also orgasm and have ejaculation, but never actually get hard. So they're all three separate things. All of the treatments that a urologist can really offer you are going to be treatment for the erection side of things. Next question is, can I take things like meds to help me sleep like alprazolam or lorazepam or Ambien, can those affect ED? And the answer is yes. It doesn't mean that you can't take it, but those medications are similar to, they're in the same class of drug and neurotransmitter as alcohol. So if you think about it, if you get really drunk or if you drink a lot of alcohol, you're going to have poorer erectile quality. Taking pills like anti-anxiety medications, sleep aids, they act in a very similar way. You may not feel the same as being drunk, but they can have a similar effect to your overall erectile dysfunction. Another question, can hernia repairs or abdominal surgeries cause ED? So hernia repairs specifically do not cause erectile dysfunction. They just don't. The nerves aren't in that area, so they don't cause erectile dysfunction. If you have bigger abdominal surgeries like big colon surgery, big rectal surgeries, prostate surgeries, then yes, there are nerves that are deeper in the abdomen that can affect your erectile function, but hernia repairs, which are kind of more towards the front part of your abdomen, do not. Next question, do you develop a tolerance to injections and then require higher doses? That is an excellent question, and the answer is no. It's the same type of idea to medications working initially, like oral meds working initially, but then not long-term. It's the same thing with injections. It's not that the medication itself is giving you a tolerance. So you should not have resistance to starting on any of these treatments. There's no reason to delay treatment. It's unfortunately the problem with aging, chronic medical conditions, and vascular blood flow to the penis, that they just have a tendency to get worse and worse over time. And so because of that, you kind of have to escalate your treatment, whether that's a higher dose of oral medication or injectable agents. You'll usually have to slowly creep up on those doses to get the same response. Next question, alprostadil cream. So there are some creams that are available for erectile dysfunction that are available through compounding pharmacies, like alprostadil or different formulations of something called Trimix in a cream form. I can't say that I have any guys who actually use those on a consistent basis and love them. They can be a little pricier than the pills. They're probably priced similarly to the injections, but the men that I've had actually try them out as an option, they often will come back to me saying that, hey, you know, they cause like a local reaction, unfortunately. Like they cause some sensitivity on the penis. Sometimes they can cause kind of hypersensitivity, like painful sensation on the skin of the penis as well. And so I don't love them for that reason. I also think that if you're going to go down that road of something above the level of a pill, you're going to get a much better response if you just put the needle in. So if you do the injections, you're probably going to pay the same amount, but get more bang for your buck and a more reliable response too with less side effects. Next one is, let's see, the different treatments. And I think we've talked about this, the different treatments, how do they relate to ejaculation? And like I was saying, I get this question all the time. The ability to get an erection is completely separate from your ability to ejaculate and orgasm. And just because you cannot ejaculate or just because you can't orgasm doesn't mean that there isn't value to sexual play or having an erection. And I think there is some mental play there that you have to be comfortable with. The other thing that I often get is a fixation on volume of ejaculate. So volume of ejaculate is completely independent from how good your erection is and actually how good your orgasm is too. So there are some men who get treated with medications for their prostate. They get surgeries for their prostate, whether it's for an enlarged prostate or prostate cancer, and you lose ejaculation. That doesn't mean that you lose sensation of orgasm though. So I think separate your mind from the ability and the volume of ejaculate and focus more on the sexual experience, because I think at the end of the day, that's a lot more important. And that's something that I can help with. Let's see. Another question is, I've heard of a drug called Stendra. How's that different from the others? That's a great question. Stendra is one of the newer, kind of more immediate release forms of oral medication. So the big heavy hitters that have been around for a long time are Viagra and Cialis. Those are the ones that have gone generic. There are also newer formulas that are called like Levitra, Stendra, Staxin. They are variations of the others. They're like mildly different, but because they are not generic, they're way pricier. I have maybe a handful of guys who swear by Staxin or Stendra and feel like it really gives them an extra boost that they can't get from Viagra and Cialis, but they're also probably paying like $20 a pill for that type of difference. And I think that it's few and far between that you actually see a big difference. But I do have a couple guys who swear by it. So I won't write it off completely. It is legitimate. It is FDA approved. Unfortunately, it's just a lot pricier. And I don't think I've really personally seen a big difference between the generic and the brand name forms. Next question is, let's see, can implants be revisited after 8 to 10 years if it stops working? Absolutely. And I actually recommend it. That's why I see my implant patients back every year, because inevitably when you wear things out, if we did things right, then you're still using it and things will wear out. And when things wear out, we go in and I put in a fresh new model. It's like a fresh new one that will work for probably another 8 to 10 years. So you do have to go through the surgical recovery again. Same process, 6 weeks of recovery before you can use it. But I think 6 weeks of recovery for like a 10-year lifetime implant is short in the overall relative picture. Are there supplements that you can take to help with ED, over-the-counter stuff that we should stay away from? And I think we touched on that already, but yeah, there's a lot of supplements out there. I think most of them are generally safe, generally. I wouldn't take a ton of the stuff that you get at a gas station. I would not pay exorbitant amounts of money for it. But I think little supplements here and there, they're unlikely to make a huge difference, but I don't object to them either. I have a question about low testosterone using creams and how maybe this patient has tried creams before, but it's not really working. And so what do we do next? So low testosterone, a lot of different ways to supplement there. There are the topical options. I think those honestly were very popular probably 5-10 years ago. But at least in my practice over time, I think I've started to steer away from those because the topical agents, like everyone's skin composition is a little bit different. So the reliable absorption of that stuff is, I think, very unpredictable. There are some guys who have gone up very high doses with those topical gels, and we just never really see a great response. So sometimes the problem is the type of supplement that you're getting. So it might just be time to move on to something different, whether it's pills or injections or pellets or something like that. There's ways to get the medication or the testosterone into your bloodstream in a much more focused, much more predictable way, like injections, like pills. And so if the topical stuff just isn't working, time to move on. Just bail and try something different. The next question as a follow-up to that is, I want to have sex. It's just the desire isn't quite there. And I think we drove this point home earlier. Testosterone is not going to be the all-around fix for every single bit of it, but it certainly can help. So if we can get your testosterone level higher and boost your underlying sexual desire, then everything with sexual health becomes like a little bit of a self-feeding loop. Like the more desire you have, probably the better quality erections you have. The better quality erections you have, in turn, you're probably also going to be more interested and more into it too. So there's like a whole circle where we have to treat everything involved on the mental and emotional side as well. That's something that I always tell every guy you got to work on within your own personal psyche and relationship too. Like nothing is in isolation, just a testosterone problem. It's always testosterone and other stuff. Next question, are implants covered? And what's the estimated cost? So implants are covered generally very well. So if you have Medicare, it is automatically covered for any man with erectile dysfunction, 80%. There may be some out-of-pocket cost if you haven't met your Medicare deductible for the year, but 80% coverage is actually about as good as it gets. So if you're over 65 or you're on Medicare, implants are a very good option for you and they should be covered. If you have commercial insurance, it's a plan by plan difference. And that's something that your prosthetic urologist, like in my office, will always look into that for you if that's something you're interested in. And most commercial plans will cover it somewhere between 70 and 100%. It just completely depends on your plan. There are some plans that completely exclude sexual health management and coverage for that. So unfortunately for those guys, we end up having to play a game of either waiting until they turn 65 to get on Medicare or changing different plans, something like that. Is it common for oral meds to lose efficacy after 2 to 3 years of use? And yeah, that's a very common story. Could be 2 to 3 years. It could be 10 years. Everyone's progression is going to be a little bit different, but losing that efficacy has to do with progression of erectile dysfunction and that severity. Next question is, does Peyronie's disease have a correlation to erectile issues? And that's an excellent question. I didn't say anything about that, but there is some crossover. So 30% of guys who have Peyronie's disease will also report some erectile function issues that got worse around the time that the curve got worse. So I think when you have a plaque and there's a little bit of a curve there, things flow better when it's straight. Like blood flow flows better when it's straight. Things flow through a pipe when it's straight in a better way than if you've got like a little curve to it. So I think that's really why a lot of guys with Peyronie's do see a decline in their rigidity of erection. And when you fix that curve, oftentimes you'll get some of that back, maybe not all of it, but you do regain some of that stability. So that tends to help. The oral meds, so the next question is, how do the different oral medications differ? And that's a very good question. In general, they vary based on timing of onset, whether or not you can take it with food or on an empty stomach, and then finally, how long it stays in the system. All of these medications have that potential side effect for things like the flushing, the headache, the blue haze, the nasal congestion. But between the different pills, some guys will actually have very significant side effects with one pill, but then not another. There's a very small chemical difference between the different variations of the oral meds, and that's where you'll see that slight tweak in difference. And so if we're trying to play around with side effects or maybe a slight improvement, I'll try a different pill. But if we're looking for no response to great response, you're probably not going to see that difference between the different formulas of pills. Next questions are about wave therapy, gains wave. So those are good questions. Wave therapy and gains wave therapy. So I didn't touch on that greatly, but we can certainly talk about it now. So that is low intensity shock wave therapy to the penis to treat erectile function. It has been proven in some European studies to actually work really nicely for men who have mild to moderate erectile dysfunction. So it's going to be something that works well for guys with erections that aren't great, but maybe are still responsive to pills. Gains wave, E-wave, all of those types of things like shockwave therapy to the penis are probably not going to be good for the man who gets zero erections on their own, or get zero erections, have tried pills and see no improvement. Like at that point, wave therapy is probably not going to get you to a point where you can have penetrative intercourse. So I do not recommend it for those men. For guys who have more mild to moderate forms of erectile dysfunction, E-wave or gains wave therapy is actually a very legitimate thing to try. And certain offices within MidLantic do offer that. Unfortunately, because it's not covered by insurance, there is a cost differential there. So a lot of the other treatments that I touched on today, they're relatively affordable. They might intermittently be covered by insurance companies, but wave therapy is not. So it can be pretty pricey. We're talking, I can't even quote you a specific price, but it's probably somewhere between $3,000 and $6,000 for the treatments. Next one, is there any direct relationship between weight loss and ED symptom reduction? Absolutely. Absolutely. If you lose weight and you lose fat content, build muscle, that absolutely shows a correlation with improvement in erectile function. You won't go from nothing to, like rock hard, but if you lose weight, if you gain muscle, you're likely to also see a boost in your testosterone, and then you'll also see an improvement in your erections too. How is testosterone measured in blood panel, and what's the normal range for a guy from 40 to 50? So testosterone is measured in a simple blood draw, doesn't have to be fasting, so it's pretty simple to do. It's really only accurate if you get it drawn relatively early in the morning. So get it drawn before 9 a.m. and you'll get the most accurate results. A normal range for men in their 40s or 50s is going to be 300 or higher. Depending on the lab that you go to, they might have slightly different lab corrected normals, but in my mind, somewhere around 300 or higher would be considered normal. That does not mean that if you have a testosterone above 300 that you are an absolute no-go for testosterone supplementation. It also doesn't mean that if you have a testosterone incidentally of 250 but you feel completely normal, that you have to have something done either. It's a mixture of looking at where you are on that continuum scale. So if you're like a testosterone of 350, but you feel awful with low sex drive, you're feeling depressed and your fatigue levels are really annoying, then I think it's entirely reasonable to try testosterone therapy to see if that improves that. So it's a very case-by-case basis. Next question is approximate cost of a penile implant. So if you were to do cash pay for an implant, which I wouldn't recommend for anyone because there are ways to get it covered. Cash pay for an implant, very roughly stated, is probably around $18,000 to $20,000. But if you have insurance that covers it, most men, their out-of-pocket cost for that, if you have 80% coverage, is going to be closer to like maybe $1,000 or $2,000. And that's if you haven't met your deductible or something like that. So there's differences in the ways that insurance companies charge you for anything beyond the 80% coverage, but it's generally affordable for a surgery, and it's covered for the most part. Like if you had a hernia repair, if you had a gallbladder surgery or any other medically necessary surgery, there may be some cost associated, but it's covered. Does an implant increase the size of the penis? And unfortunately, no. So an implant does not make you any longer than you are. It doesn't make you any wider than you are. Implants are tailored to you internally. So in the operating room, when I do an implant, I measure every single man. And I give you every centimeter, half centimeter that your body will take. So I will not shortchange you. You will get everything that your body will give. But I can't make you any bigger. I can't make you any wider than you were designed to be. The implant itself has kind of like a specified girth to it. So there are some men who just by nature have a thinner penis with erections. And for those guys, technically you might see an increase in girth. But for most men, I think that the girth is probably comparable to what they normally would have. It's the length that a lot of guys will think about. And unfortunately, I can't give you anything longer than what your body can give. Next question, how likely is Peyronie's to come back if you have a plication procedure, and how long do XIAFLEX results last? So in general, how long do these different treatments last for Peyronie's? They usually last you a lifetime. We think about Peyronie's as one instance in time where there was an injury and you form a plaque. We let that plaque mature over a 9 to 12 month period. And after it's stabilized, then we fix it. So it's not like you're going through repeated injuries, always having an evolving curve. You had one thing happen, a curve resulted, and then we fix it. So usually if you get a result where things straighten out after either injections with XIAFLEX or a plication procedure, which is that surgery that we talked about, then the result that you have should be long-standing. Like the result that you see after surgery or after injections, that's it. It's not going to get better. It's probably not going to get worse either. Next questions. Where can you find out what mental health meds have lesser effects on ED? Yeah, so that's a good question. In general, The only mental health med, like the depression med that has the lowest stated side effects for erections, is going to be Wellbutrin. Almost every other one has relatively high incidence of sexual side effects. Wellbutrin does as well. It's just that Wellbutrin has the lowest incidence of side effects. Next question. Any comment on premature ejaculation? Yeah, so premature ejaculation is something that's incredibly difficult to treat. So that is not something that we as urologists have a golden ticket or silver bullet to treat. A lot of it is kind of pattern play. So personally going through and figuring out what might make you last longer during sex or during foreplay is important. Other things that we can try, they're not perfect, but other things to try would be like desensitization creams, like lidocaine, prilocaine creams that we use. Other things would be use of condoms because that decreases sensitivity. Another thing that we try sometimes are oral medications. And this actually ties into the previous question with antidepressants. So antidepressants actually tend to make it harder for men to reach orgasm. So we will actually, as urologists, sometimes flip that on its head and use low doses of antidepressants as a way to prolong the time to ejaculation. Unfortunately, they can decrease your overall erectile quality as well. But most guys that we see with premature ejaculation usually have really good erections. It's just things happen too quickly or it's like too accelerated. So for those guys, a low level antidepressant can actually help. Another question is just about timing of daily tadalafil. So tadalafil is generic Cialis. That is great for erectile function, but in the more recent years has also had an application in BPH or an enlarged prostate. So a lot of guys that will actually take it every single day, and it kind of pays it forward both for voiding symptoms like improving your urinary stream, but then also improving your erectile function. There's not a specific time of day that you have to take the med. You just take it consistently every single day. The beauty of Cialis or tadalafil is that it's very long acting. So you can take it in the morning and still have it circulating in your system midday. You could take it in the evening and still have it circulating in your system for the morning if something were to happen. So, you know, the timing is nice there. Another question I get often, and this is something that someone's bringing up, is does a large prostate produce erectile dysfunction? And the answer is no. An enlarged prostate has nothing to do with erection issues. Enlarged prostate and different treatments for enlarged prostate can affect ejaculation, but they should not affect your ability to get a rigid erection. And then final question on my list here is, can you have testosterone replacement if you have had prostate cancer? And the answer is yes, but it's a yes with an asterisk. So one of the risks of testosterone therapy, and something that we watch closely as urologists, is that testosterone can feed prostate growth. It can feed prostate cancer growth as well. So if you do not have prostate cancer, you can have testosterone therapy, but you can bet your urologist is going to be watching your PSA levels to make sure that we're not unveiling or uncovering some prostate cancer that has not been previously diagnosed, because then we'd have to manage that and treat that. On the flip side, if you have had prostate cancer and you have been treated and you're in remission or cured, you can get testosterone replacement therapy. It is something that we watch carefully, because if there are any iota of remaining prostate cancer cells, then testosterone supplementation can encourage those cells to grow and show itself and potentially spread to other areas. So that's something that we watch really closely. It makes people probably a little bit more touchy about and more cautious about starting testosterone if you have a history of prostate cancer, but there are exceptions to every rule and there are responsible ways to do it. And so it always has to do with monitoring and being smart about it. You're still a candidate to get testosterone if you have prostate cancer that has been successfully treated, but you'll be on a close leash with a urologist. So I think that concludes all of the questions that I have listed here, and just really want to thank everyone for signing in. Hopefully everyone came away with, you know, some fun facts or something that makes sense or is interesting. I think the takeaway that I always have for my patients are, don't be ashamed. Don't feel like you're doing something wrong, because you're not. This is something that's extremely common that a ton of guys suffer with, and suffer with is something that a lot of guys do with this. They suffer silently, or they suffer with it and they don't seek treatment. And I'm here to encourage you, please ask your urologist. We are all more than happy to talk about it. We are all there to help along with it. And a prosthetic urologist can offer things at higher levels if you end up needing something like an implant. So I will sign off, and I hope everyone had an educational time, and I hope everyone has a good night. All right. Good night, everyone.